evening, everybody. Good evening, everybody. Obviously, I'm Steve Bryan. I'm your local MP. Welcome to Ask the NHS Returns. This series of meetings, the Ask series, started back in November 2012 when we had the Minister to come and talk about UK international policy, actually. And we've had Ask the South West Trains, and we had our first Ask the NHS meeting back in 2014 to then talk about potential future new hospital services. We then had another Ask the NHS later on that year to talk about obstetric and maternity services. And then we had one to talk about also future services in January 2017. So it's been a few years. I was hoping to have one last year, but I won't even begin to bore us with why that didn't happen. You all know why. The purpose for this meeting is that we were, I think, probably expecting to have been underway with a consultation around future services at Winchester, Basingstoke and Andover Hospital at this time. And as reported in the local press over recent days, that is now not going to happen until later on this year, subject to approval from the commissioners and the regulators. But that doesn't mean there's not an awful lot to still discuss. Last year, the Trust underwent a big proposal called Hampshire Together, a big consultation process, which went on for much of the middle part of last year. And we're going to talk about that and what was the drivers behind that, what are the future services review that looked at. And as I said in the email to you all with your link, you know, the clue is on the tin. The meeting is called Ask the NHS. It's not just ask about Winchester Hospital. There is obviously much more to the NHS than acute hospital services. There's primary care services, there's pharmacy services, there's mental health services, there's community services, and all of that is part of the Hampshire Together process, and all of that is part of what makes the local NHS tick. So you can ask about anything. You can ask about COVID catch-up services, you can ask about parking at Winchester Hospital, you can ask about access to GP services. We have three clinicians with us on the call who should be able to cover all of those different bases. So obviously we have Alex Whitfield, who is the Chief Executive of HHFT, Hampshire Hospitals Foundation Trust, Lara Alloway, who is the Chief Medical Officer of the Trust, and Dr. Matt Nisbet, who is from the commissioning group and can speak around primary care. So just to kick us off, as I said in my note, what we're going to do, I'm going to ask Alex to just sort of set the scene for us as to what Hampshire Together was all about, what the drivers were behind it. Then Matt is just going to give us a couple minutes of primary care update and rollout of the vaccine, which is where the hope lies. And then we'll throw it open for questions. And we've got a hard stop of 7:30 because it's a beautiful evening, and I'm sure we've all got other things to do. But thanks for joining the call. And Alex Whitfield, over to you.
Thank you, Steve, and thank you everybody for coming along this evening. And yeah, thank you, Steve, for organising this. It's always great to talk to the people we serve, our population, our public. So yes, Steve asked me to give you a little bit of a background and overview of Hampshire Together, and I recognise a number of faces of people who will know this programme very well, but just in case there are people who haven't been on the journey with us. Hampshire Together, it has come out of the government's plan to build 40 new hospitals across the country. And we're incredibly fortunate that Hampshire Hospitals is one of the trusts that is part of the programme. And we called our programme right from the beginning, Hampshire Together, modernising our hospitals and health services, because we wanted to use the opportunity for new capital investment as a way of improving and continuing to improve the delivery of healthcare. And for us, that means providing as much as we possibly can close to where people live. So using digital technology to provide things in people's homes, and I'm sure a number of you will have experienced some of the digital interactions with the NHS over the last year, but also providing care in GP surgeries, in community settings, close to where people live. And then providing really the acute, capital-intensive, people-intensive services for a broader population from a new hospital. So we've approached this programme as very much not just a building programme, but it is about a whole service redesign programme. There are 4 drivers for change, 4 reasons why we think Hampshire got identified for one of the new hospitals. The first is our population growth. So many of you will have seen there is a lot of house building going on. There are more people moving into our area, but we also have quite an aging population. So our age profile is going up all of the time. So we're looking at things like over 40% increases in the over 75s over a period of about 7 years. And people, as people age, they need the NHS more. So we need bigger facilities, better facilities, newer facilities. The second reason is the condition of our buildings. Now, anyone that's been into the Royal Hampshire County Hospital recently will know that some parts of it are amazing and in really good condition, other parts less so. You know, we've had real problems with our lifts recently. Anybody who's working in the hospital will know. But there's lots of core infrastructure around the electrics, the roofs. We haven't been letting people out into the courtyards because the tiles are falling off the roofs. The building is starting to show its age. The same is true in Basingstoke and to some extent in Andover. So part of the reason we're on this programme is because our buildings are recognised as being in need of significant investment. The third reason is clinical sustainability. So what that means is that some of our services are at a smaller scale than would be recommended by things like Royal College guidance in order to provide the very highest quality care. And this is because for a number of services, you need the most expert doctors, the consultants available 24/7 in one location. And that's really expensive if you're trying to run it across 2 hospitals, Basingstoke and Winchester today. And so what happens is you don't always get the consultant there. You might get a more junior doctor because actually we either can't find or can't afford the levels that would be ideal. Now, in reality, our outcomes for patients are really very good. So we don't necessarily see that translated into outcomes. And I don't want anyone to be anxious about the quality. But on an ongoing basis, it's not considered sustainable. And we can talk more about that. And Lara can pick up more of that if you've got questions. And then the fourth reason is financial sustainability. So again, running these acute, expensive services in both Basingstoke and Winchester is more expensive than running them in a single location. And so as a result, we end up spending more of the money that we're given to look after all of you and your neighbours on our hospital services. And we want to be able to spend more on services close to home, on other types of care, everything from children's mental health services to primary care services to all the other demands that we have on the NHS purse. So those are the 4 reasons. It's about population growth, the condition of our buildings, clinical sustainability, and the finances. So we were delighted, absolutely delighted, thrilled that we were on this list. And I know Steve was equally delighted to see it there. And we've been developing some options and proposals, and a number of you have been involved in that. And where we've got to at the moment is, and we've come out to the public about this, that we have a couple of different site options for the new build, one at junction 7 of the M3 and one at the current Basingstoke site. And we have some really exciting plans for the Royal Hampshire Hospital, which would be our main local hospital under these plans, and have lots of the services that you know and love, but also potential for additional services, including additional surgical services, planned surgical services. So we've got a number of options that we're still developing. As Steve said, we were hoping to be out to consultation about now, but as we're part of the national programme, there are some elements that they want to be consistent across all of the new hospital programmes, and we need to play those through into the options that we've been developing locally with many of you before we can take them out formally to the public. So we're hoping to be in public consultation at some point in the not too distant future, once we've been able to play through those national assumptions. But I absolutely want to assure you that investing in the Royal Hampshire County is part of Hampshire Together. It's also part of what we're doing right now. So many of you will have seen building work going on. We've got our beautiful new hospice that we're hoping to open in August. We've got work going on with our pharmacy department to put in a pharmacy dispensing robot and have a whole new pharmacy department. We've got plans to create a new orthopaedic outpatient department. We've invested in our digital technology, in our emergency department. You will all have seen at the front of the Royal Hampshire on Romsey Road, the emergency department additions that we made before COVID, and thank goodness for that, and then some during, because it's increased the space we've got available there. And we are also investing in things like the electrics and the substations and the lifts and the things that you don't quite see, but we absolutely need them all to work. So I just want you to hear that we are completely committed to the Royal Hampshire and really happy to take that conversation further. But Steve, if it's all right, shall I hand over to Matt to just talk a bit about primary care and vaccines?
Yes, just before you do that, just to say to everybody that obviously the rules of the dreaded Zoom apply. Please keep yourself on mute, which you all have. If you wish to ask a question, don't type the question in the chat. Just put I want to ask a question to all, and then I will call you forward to ask your question. There have been some that have been submitted to me in writing from people who couldn't make it, but this is your chance to ask your questions. Alex, just to say a supplementary to what you said, yes, as you know, Alex and I have some very robust conversations, as it should be, but the truth is that politicians don't and should not design NHS services, but they should channel the view of you into the people who do. And that's really what I do on a day-to-day basis, but that's what this meeting's about. Yes, I'm pleased. Who wouldn't be pleased to have a brand new hospital serving his constituents? But, there is going to be a rub to that. You're not going to have all the same services in Basingstoke and Winchester and a new hospital between and a major trauma centre at Southampton. There is going to be a trade-off. And as everything in life, and certainly in medicine, you give something away to get something. And my challenge to Alex, as she knows, has always been that I expect the clinicians to own that, and I expect the clinicians to be 100% upfront with us as to what we trade in order to what we gain. And I think if they do that, as they go to public consultation, then I think that we will all be well served by what is, by any measure, a very, very professional and competently run trust here. We are very well served, but that doesn't mean that I don't ask them difficult questions, and I hope you're going to do that tonight. Matt, if you want to unmute and just say a word, please, about primary care and about the vaccine rollout. I should think most people on the call have had at least one jab. Matt, over to you.
Thanks, Steve, and thanks, Alex. I'm Matt Nisbet. I'm a local GP and I'm Associate Clinical Director with our Clinical Commissioning Group. I'm not going to talk for long because, as Steve says, really the point of the evening is that there's an opportunity for you to ask questions, but I'm just going to say a few words. I thought I'd start by just trying to explain in a sentence or two what Clinical Commissioning Groups do, because they have a very back office function within the NHS, and that they're not the kind of organisations that most people will deal with on a day-to-day basis. Clinical commissioning groups broadly buy healthcare on behalf of the population that they serve. So clinical commissioning groups commission something like 90% of the services that you will all use. The only exceptions are very specialist services like transplant services. Our clinical commissioning group covers, since April, covers Hampshire, Southampton and the Isle of Wight, which is a very big area. So as you would expect, we've broken it up into smaller bits, which is where local doctors like me come in, and we've organised our local bit around Hampshire Hospital's footprint. So our local patch looks after Basingstoke, Winchester and Andover. The CCG has an important role in the Hampshire Together process because it's the statutory organisation which deals with consultation on service change and which makes a decision on whether or not to go forward with public consultation. So it does have an important part to play in that process, and in working with providers across Hampshire and the Isle of Wight to improve the quality of services that we all use on a day-to-day basis. So I'm very happy to answer questions about Hampshire Together. We're as keen as I'm sure everybody on the call is to move forward with the consultation process. But as Alex has said, one of the aims of the Hampshire Together programme is to provide as much close to people's homes as possible, and actually this time that we've got does give us an opportunity to think more about how we do that, to think about how and where we provide things in people's communities, and to develop those plans that we've got. The services that are provided, particularly by GPs, but also by my hospital colleagues, have changed enormously over the last year. We've probably changed more in the last year than we have in the last 20 years before that, to be honest. And I'm very aware that as we come out of the kind of lockdown time, the pandemic time, that some people have had difficulty with their GP services, and I'm very happy to answer questions on that too. Access to general practice is really important. GPs and our teams have worked really hard to try and maintain that access. And there is an issue at the moment, isn't there? GPs are carrying out 20% more appointments than we were a year ago, and yet people are still finding it difficult to get through to us and get hold of the services they need. And I don't have an answer for you tonight on that, but I'm very happy to talk about it. As Steve has alluded to, one of the reasons that GPs and our teams are so busy is because we've been working hard on the vaccine rollout. 75% of the vaccines given across the country are given by GP-led centres, and I hope some of you have had good experiences of our centres in Winchester, at Badger Farm and at the Holiday Inn. Across Hampshire and the Isle of Wight, we've given 1.76 million doses of vaccine, and in people between the age of 40 and 44, 88% of those have had their first dose. So we're really moving down into the younger age groups now, and the vaccine rollout has been a success story, I think, for all of us. I think that's all I wanted to say.
Okay.
Hopefully that
Yeah.
sets the ground.
No, that is fine. Okay, so put your questions, or put your I'd like to ask a question in the chat, or just raise your virtual hand, or raise your physical hand, and you can ask the first question. Okay, Jenny McRobert, unmute yourself, Jenny, and you have the floor.
I actually have more than one question, so I'm not quite sure which one to ask, but
the most important one.
The most important one, gosh. All right. If we're going to no longer have a city centre hospital, are there going to be transport services provided for people who are used to, obviously accessing the hospital in Winchester? So if it's going to be at junction 7 of the M3, that's not actually very far, but if you don't have transport, it's probably impossible. Or somewhere in between Basingstoke and Winchester. So what's the situation on transport services?
Yeah, it's a really good question. To be clear, Jenny, nobody's saying there won't be a hospital in Winchester, but transport is a big issue and comes up every time we do these meetings. So Alex, the transport issue, which you will have to consider as part of any consultation.
Yeah.
What can you reassure Jenny with?
Yeah, so I mean, the first thing, and I'm really sorry if you've got an impression there won't be a hospital in Winchester, there absolutely will be. And for the things that people go to most of the time, it'll still be at the Royal Hampshire County. So, we see 11,000 outpatients a week. They will still be locally to wherever people live in Winchester, Andover, whatever. The diagnostics, the MRIs, the CTs, the X-ray, there'll be loads of stuff. So, but for those, if there are things where, which you do need to go to the new hospital, so such things already exist today. So as Steve said, the major trauma unit today is in Southampton. So even if you live in Basingstoke or Winchester or Andover, you would have today go to Southampton. Similarly, cardiac services, if you have a heart problem, you'd go to Basingstoke, Southampton. So people already have this today. But we are absolutely clear that transport, it comes up every time we talk. So I'm not surprised it's your most important question. And I guess there are several answers. The first is we're clear that wherever we put the new hospital, it's going to need really good parking, because that's a lot of people do drive or are driven. So we need to make sure that we've got good facilities for people that drive or are driven. It also needs to be really accessible by public transport. And so we've got a transport group that's working with the boroughs and the districts, so Winchester City Council, Basingstoke and Deane, Test Valley, Eastleigh, and with Hampshire County Council, to look at what would the public transport offer be and how could we ensure that people could get there patients, but visitors as well, if you're visiting someone in hospital, and staff. So it's a really important part of the programme, definitely. Yeah.
Okay, thank you. Jenny, does that help? Does that help answer your question?
Yes, it does help actually. And I hadn't realised that we are going to keep some services in Winchester. Does that mean you're going to modernise the current hospital, or is it going to be on a different site? Sorry, it's another question, but
no, not at all. It is the key question. I think the trouble is, Jenny, is that you know there are the social media is a menace, and there are things out there, you know, saying save Winchester Hospital, which you would be forgiven for thinking would mean that Winchester Hospital is going to disappear and turn into a housing estate. You know, that is not going to happen. But there is a conversation about the services that will be between New Hospital, Winchester Hospital, Basingstoke Hospital, Southampton Hospital. You know, there are things that you do in lots of places, and there are things that you specialise in certain places. You don't do everything everywhere, and it is that is causing this friction, that is causing this conversation. But Alex, in respect of Jenny talking about modernising Winchester, I mean, there's a lot of money being spent there in recent years.
Yeah. So yes. So we will be, as part of this programme, we will be continuing to invest in the Royal Hampshire County Hospital on the Romsey Road. We're not proposing to build a different hospital in Winchester. It is the current Royal Hampshire, and it's about some of the premises are actually in relatively good condition. So that the Burrell wing, which is where we have our day surgery and things like that, is quite a good structure. So that's in good condition. There are other parts, and the bit we actually sold a little while ago down at the old outpatients was in terrible condition with buckets and everything. So the new outpatient facility that opened a few years ago now is great. So yeah, we'll be continuing to invest in the Royal Hampshire. Absolutely.
Okay. Thank you very much.
Thanks. Okay, I'm going to come to Carol Hastings and then Bryony. So if you stand by, Bryony, you'll be after Carol Hastings. Carol, if you'd like to unmute, then go ahead.
Yes, thanks very much. At one of the recent Hampshire Together sessions, Luke Nolan talked about the impact of COVID on the delivery of chemotherapy. And he said that the team had actually delivered a brilliant service in ways that they'd never thought about before COVID. So I'd be interested to know what learning, what's the impact of that learning, and what kind of chemotherapy services we will have in Winchester locally, short term, and obviously when the new hospital is open. Thank you.
Great question. Maybe one for Lara. Maybe one for Lara Alloway. I think that question, Lara.
Yeah, thank you, Steve. Good evening, everyone. So our cancer services during COVID, we moved from Basingstoke and Winchester to Sarum Road Hospital. And the reason that we did that was to protect people who were very vulnerable from COVID and catching that infection. And actually, we ran our chemotherapy services for just over a year there, really successfully. And there were huge advantages of bringing the two services together. I'm sure some of the developments that Luke talked about were, we ran a drive-through service to pick up chemotherapy rather than people having to come in if they didn't need to. We did a lot more remote consultations, so video consultations for people, again, who didn't necessarily need to come in. So we really reduced the amount of journeys people had to make and waiting around and things, and saw the benefit of bringing two smallish services together. We also appreciated totally that people needed to feel safe. It was a very scary time to be immunocompromised, so more at risk from infection. And our cancer services have now moved out of Sarum Road, and the chemotherapy services are being delivered from a separate building on the Basingstoke site before they move back the Winchester services to Winchester. And this is a phased approach that as we move our services back to where they originated from. But actually, you know, we have made sure that people have had 24/7 access to advice. And as I say, making sure they didn't have to travel if that wasn't absolutely required. So we take all that learning. We've done some understanding. So some of our governors have helped, and our patient groups to get some feedback of what people felt about this. And that's been really, really useful in planning the next few months of the service. So, you know, the big thing we are very proud about is that we did not stop delivering these cancer services. And there's been lots of sort of frightening things in the media about hospitals that had to reduce down, and we didn't. And we were able to carry on. And I think that's, you know, credit to the patients and their families for supporting that, but also our staff who did brilliantly and moved incredibly quickly. I'm really supported by the Sarum Road Hospital staff as well.
Thank you very much. The trust and the local healthcare system were very good we had weekly calls with all the local MPs during the height of the crisis, and the oncology service came up time and again. And we, as in government, spent a fortune on contracting the private sector to be the cold sites, so that we could not mix, obviously, people having cancer treatment with COVID patients on the main site. And Sarum Road was part of that contract. But thank you for that. Okay, well, on to Bryony, and then after Bryony, it'll be Fran Golder, then Mike Greta, then Caroline Horrell, then Charles Pascal. So they're the ones that I've seen so far. So Bryony, over to you.
Thank you. I'm Bryony Farrant. I'm the new coordinator of the National Childbirth Trust in Winchester, the NCT. So my question is about maternity services and postnatal and antenatal care. My understanding is from the proposed changes is that consultant-led care would be taken out of Winchester. So a three-pronged question really. One is that the case, and could you explain what the proposed changes are to maternity services? And linked to that then, how do you think that will affect the birth choices for parents-to-be, perceived and actual, taking into account that people make their choices about their births on the basis of, for example, how close is the nearest hospital if I'm hoping to have a home birth, for example? And then linked to that, what do you think the impact is going to be on safety of the mother in birth and safety on the baby, taking into account, for example, the need to transfer perhaps urgently for emergency surgery in birth?
Bryony, thank you. I declare Bryony and I had a very long conversation about this, and I'm really pleased that you're on the call. And thank you for speaking to your networks to make them aware of the call. I don't know whether Lara is a medical officer question or whether it's in the first instance. Yes, Alex talked about certain services that would be challenged to continue to be served in multiple sites as opposed to one site. Is it the case that consultant-led obstetrics is one of those? And what's the answer to Bryony's question?
Yeah, no, thank you, Bryony. So absolutely, as Alex said at the beginning, there are some of our services that are smaller and we're providing twice, so are more challenged. And maternity services and neonatal services are some of those. So we're still developing the final options, but we do have options whereby the consultant-led obstetrics would be moved to the acute centralised hospital. We do have an option where it will stay in Winchester as well. So, and the answer to your question about why are we doing that is we know that the number of births in Winchester and Basingstoke are under the sort of number that you would expect for the level of neonatal care and keeping the services safe and up to date, and providing the consultant cover for the hours that we believe are safe and have come in from the Ockenden review is a real challenge. So we also know that we're not providing the choice that women want. We don't have alongside midwifery-led units, and we know that people are asking for that. And we've been working with various people, including Mindy and various people representing maternity services to, and we're very clear that having alongside midwifery units is really important to people. So our options include both. I think safety is a real question here. Now, for all options, we would still have antenatal and postnatal care on the Winchester site. And, you know, the things that people regularly, or not regularly, need to attend multiple times, we would have as locally as possible. And as you know, we have various ways of delivering our midwife care, and sometimes that's out in GP surgery, sometimes it's community services, and we have our home birth service. So there is a number of different ways. the Ockenden review that was published in December that people may have seen in the media was all about how we make sure that people with high risk deliveries are best cared for. And, you know, that requires intensive obstetric support and other support associated with it. So for safety, there are significant advantages of centralising the obstetric-led delivery service. So, but recognising that we still want to have a midwife-led unit and antenatal and postnatal care in the option where we centralise in Winchester. Now, we do have an option where we provide still, as we do now, obstetric-led care in Winchester, as well as in a new acute hospital. And then what we will need is a neonatal unit to support that, as we have now. But our neonatal units are not looking after enough babies to continue to provide the intensive care that they provide now. So actually that would mean that they would be downgraded to a level 1 neonatal unit to support the obstetric-led service. So there are some interdependencies, and what that would mean is that that would be for the acute hospital as well as Winchester if we were splitting it. If we centralise neonatal care, then we will be able to keep the level 2, so that's looking after babies from 27, 28 weeks and onwards. And as you'll appreciate, it's not just deliveries, but it's threatened deliveries would potentially need to travel much further if we were only providing the level 1, which is older babies. So I think your questions are brilliant because they're completely interlinked. So we have options for all, and clinically, you know, we want to absolutely hear from the population. So when we go to consultation, what's important to people, and you know, we need to be, as Steve says, we want to be really clear on what we consider to be the safest way of delivering services, and we've got to balance all that up, haven't we, in the delivery.
Okay, Lara, you know, this is the thing that most concerns me. And Bryony wants to come back on this. Bryony.
Yeah, I mean, I really take the point about the safety for high-risk pregnancies, but I'm imagining, I don't have the stats, that actually that represents quite a small number of pregnancies compared to the average number of pregnancies in birth. And I suppose I'm wondering about those scenarios where actually the birth wasn't flagged as a high-risk pregnancy, but suddenly becomes high risk and requires a transfer, and how that impacts not just on the safety, but also on the psychological experience for the mother and the father, and what that means for actually their experience of a positive birth, which we know that has been identified also in previous reports as being really important.
Yeah, no, absolutely. So I think it comes back to the same answer in some ways, doesn't it? Because actually, if it's not flagged as a high risk and then they're having a home birth and they need transfer, actually what they need is to have the right staff available at all times when they get there. And that is better achieved if we've centralised our consultant-led service, because at the moment we don't have consultants present 24/7, but we would be, if we centralise the consultant-led component, we would be delivering that. So I completely agree with you. So the impact on the transfer time is the key thing, and we've been working through with the ambulance providers, with SCAS, on, you know, the different scenarios there. So, you know, I think it is absolutely a balance, and I think it's about being open about what the choices we have to make are. So there is a choice, and if, you know, we are expecting some people, remembering, you know, people live all around the area, some people will need to potentially travel a little bit further, but when they get there would be more like, you know, 24/7, a consultant would be present, and all of the infrastructure there, and the neonatal unit, even for the younger baby, would be there. So I think it is absolutely a balance.
Lara, where can we find more information? Because never in this area of medicine, more than any other, we need to deal with facts and evidence and not scare the life out of mums, expecting mums. so Bournemouth and Poole had a similar configuration to what you may be proposing for Winchester and Basingstoke, and there would therefore be transfers between those two. I mean, Northumberland in the northeast, where they built a critical treatment hospital, they presumably had that same dynamic. Is there a way that I, as the MP, can produce some information that I can channel out to constituents through the press who I know are on the call about the compromises that were required there and the impact that that's had? Because we have to deal with the facts on this, because otherwise we are going to scare people witless. And maybe we need to, but I'd rather deal with the facts.
Yeah, I mean, we're very happy to work with you, Steve, on getting the right information, and we've obviously got all of the data on people who've used our services. So you know, we can absolutely work with you. There are various resources for understanding this, and as you say, many places have been through this. I think, you know, we are trying to make sure that when we come to consultation, talk about these different options, we can explain the different scenarios and the implications. So we are absolutely working on this, because I think, you know, it is about being open and honest with the information that we have.
Okay, thank you, Bryony. I hope that's helpful, and I know you are the new branch coordinator for the NCT across Winchester and District. I hope that you will see this as the start of a conversation with the trust, and they feel they can talk to you.
Yes, I was just going to say thank you very much, and I'd really welcome ongoing conversations about
Brilliant.
this. Thank you.
Thank you so much, Bryony. Fran Golder. Please go ahead. You still on the call, Fran? Obviously not. Okay, we'll come back. Mike Gretton.
Thanks, Steve. My question is rather wider than your own constituency, but a basic principle of the Hampshire Together philosophy is not just a new hospital, but greater integration of care across all the agencies within the NHS, external, and I think prevention of illness as much as curing illness. Could somebody, and I suspect it's Matt, explain what's happening across the whole patch of Hampshire, which may include Portsmouth or not, I don't know, but Southampton keeps being mentioned as a separate unit, and the Isle of Wight. We have alphabet soup, STP, ICS, CCG, sorry, probably in the wrong order. Could somebody explain what the relationships are and how that will impact eventually on us in our area?
I can have a go at that at the start, actually, Mike, and then I'll ask Matt to briefly come in as well. I mean, look, we are about to bring a new health and social care bill to Parliament. It was announced in the Queen's speech the other day. It will create formally, legally, something called integrated care systems, which will be coterminous with Hampshire. And probably the Isle of Wight as well, although I'm discussing that with the Health Secretary at the moment. But they will bring together, they are all about integrating services. So integrating tertiary care, primary care and community care services all under one roof, under one budget holder. The so-called Lansley reforms, as you know, Mike, everybody was former chair of the old Winchester and Eastleigh Trust. As you know, the Lansley reforms created a purchaser in the CCGs and a provider in the trusts. This brings that together under the integrated care systems. And yes, it is about integrated care, and it is also about prevention of services. But Matt, would you like to add to what we're trying to achieve with ICSs, which I know you know quite a lot about?
Absolutely. Yeah, I mean, I have to be careful because I could probably talk for the rest of the evening about it. But I mean, see, so the aim of the Lansley reforms that Steve mentioned was to make the commissioning of health services more locally focused and more clinically led. And I think whatever people thought about that at the time, I think to a large extent those reforms have succeeded in that. You know, it's because of those reforms that you have people like me talking to you this evening. The difficulty with those reforms and the criticism of them, I suppose, over the last 5 or 6 years has been that some of the strategic influence has been lost. So, for example, Hampshire County Council have found it quite difficult dealing with a number of different clinical commissioning groups when it comes to things like organising social care. And of course, the integration of social care and healthcare is important in making sure that things work smoothly for people and for patients. And so STPs were a way of trying to address that across a bigger footprint. STPs, I think I'm right, have recently stopped existing really as organisations because they've
that's right, because we're creating the ICSs.
Yeah, because they've been replaced essentially by integrated care systems.
But anyway, look, you are right, Matt. You could talk about this all night, and I'm going to brutally stop you. So I'm going to ask Fran's question because she put it in the chat.
I'm sorry, Steve. Before you go away, can you just clarify? You said that there'll be a centralised budget for health and social care in our area. Is that correct?
That is my expectation, but the bill has yet even to be published in draft form. So I am merely surmising what I heard on a call from the NHS Confederation today. It is not. I can't clarify what the legislation says because it hasn't been published yet. But that is my expectation, and it certainly would be logical based on what I'm saying has happened. Thank you, Alex. I might just ask you. Fran asked the question: how many beds would you expect to remain at the Royal Hampshire under plans that could happen? And so, which conditions, for instance, a 12-year-old with an acute appendicitis, would that still be treated at Winchester? Maybe could you answer that?
Yeah, so if I pick up the beds, I think some of the clinical conditions that Fran's put in there, Lara, would be best placed to give medical advice for those patients. In terms of the number of beds, so we have a variety of options that we are developing that are not, when we're ready, when we go out to consultation, we will have them clarified for definite. But at the moment, the options we've got vary hugely. So there are options that reduce the number of beds. There are options that keep a very similar number of beds to those we've got today, but actually in a different service. So one of the things we're talking about is this planned care surgical centre, where actually we would do planned operations, so not the urgent things, the things you wait for, in Winchester for a bigger population, and be able to get some efficiency. So in that case, we would have a lot of the current beds still in use, but perhaps being used for different groups of patients than today. So it's kind of a little bit of a how long is a piece of string until we come out with our options and we're able to say, right, under this option it's this many beds, under this option it's this many beds.
But are your options moving? Because surely the pandemic has shown that the acute sector wasn't big enough. We had to create more capacity across the NHS in order to deal with the surge in cases. And as much as I'd love to believe this was the last pandemic, I suspect it won't be. Are your options flexible and changing based on that?
Yeah, well, so, and there's two ways that the hospital sector space wasn't big enough. There is one that our waiting lists were growing even before COVID, and now we have built up a backlog. You'll have seen that in all of the press. That we need to work through, but we didn't have enough capacity before COVID to keep up, and now we've got a backlog. So there's that bit, but then also the space that you need is much greater now. So we're trying to keep everybody 2 meters apart. We're trying to say that maybe where previously you might have had two patients in a two-bedded bay, you maybe only have one. So we need to create additional space now, and it maybe we can move people back closer together again, but you're absolutely right, Steve. What we want to build is something that is robust to a future pandemic, should that be needed.
Okay, thank you very much. Councillor Caroline Horrell is on the call. Welcome, Caroline. Unmute and over to you.
Good evening, Steve, and thank you to all of the team from the Hampshire Hospitals Group for your contributions and your input. My question is that obviously Winchester is the county town, and the title of the hospital is the Royal County Hospital, and in this discussion, and I note earlier, I think, Alex, you said that you were part of a national discussion as well before you came out to consult with us further. what are the expectations that residents should have for a county hospital? Are there basic parameters that should fulfil, and basic services that you should provide, or we hope that you can provide? And also, if all of the residents locally said, we absolutely don't want you to do this, we want particular services to be here, do their wishes, and if they were to conflict with the sort of clinical medical direction that you'd like to take us in, how are their views taken into account? So sort of 2 or 3 subsets within there. Thank you,
question.
Steve.
And I can add to that. So Daphne Taylor put in the chat, how much does the CCG actually take on board the public patient concerns? You know, is a consultation a process that has already been decided upon, or is it a genuine consultation? And it is a fair question. So Alex, I'm going to start with you on that, please.
Yeah, so the first question about, is there a sort of specification for a county town hospital? There isn't one. They do vary a lot. It varies today, you know, even in Hampshire, if you looked at Southampton, Portsmouth, Winchester, Basingstoke Hospital, they all provide slightly different services and have different specialties, because actually there are some things that are better done at scale on behalf of a bigger geography. So there isn't like a standard, there isn't even a sort of minimum data set that says, well, at the very least, you do this level of diagnostic, this level of urgent care, this level of plan. So it's really for the local teams to determine what's right for our population. In terms of the second half of the question, and Matt might want to come in here. So consultation it's not a vote, and actually what we want is a really rich conversation with the public that isn't just pick an option and, you know, 60% chose this and 40% chose that. It's much more about saying what matters to you. You know, that Lara talked about, we can provide safer maternity care for the majority of women if we centralise our maternity services, but it means that some people may have to travel a little bit further. So it's the question to the population, which of those two is more important to you, kind of thing? Do you understand what as Steve said, what the pros and the cons are, and on balance, which is more important? And if travel is an issue, then tell us that it's an issue in a way that we can try and mitigate it and support and minimize the travel, the number of people who have to travel. So we'll provide as much as you can locally. And then in those odd occasions where you have to travel, how are we supporting to make that as easy and simple as possible? So it's a much richer conversation than just I pick one. It's about really understanding what matters to people, and then what we can do to, whatever we choose, there will be some people who see that as the wrong answer. So how do we make it better for those people, given that they didn't get their first choice? What can we do to help make it better?
And presumably, Alex, you know, the answer is involvement. I mean, you know, it is very easy to click a petition. It is harder to spend an hour and a half on this meeting. It is easy to send a tweet. It's harder to be part of a consultation. The answer is surely that we got to speak up.
Yeah, definitely. And you know, speak up in a rich, detailed way, not just a yes no way, because then we can really respond to what are the specific things that matter to people. Okay, and then Matt, just briefly, this is will be a proper conversation, right? And you're interested in what we're saying. It's not a process to get to where you wanted to get to.
Absolutely. It's completely a proper conversation. I mean, at the beginning of the call, Steve, you said that you expected the clinicians to be open and upfront, and I think we've been upfront and open the whole way along, both with you and with the public and our population. Actually, there are absolutely no kind of backroom deals. It's not a foregone conclusion. A decision hasn't been made, and there are some really difficult things in all of this. One of the reasons for forming integrated care systems is because we have a health system with a finite amount of resource, a finite amount of money, and some of the decisions that as health service administrators we have to make are around the way that we spend that to gain the maximum benefit for our population. And they are difficult decisions, and we actually really need people to be involved and engaged with those, not only in the Hampshire Together programme, but also in some of the other difficult stuff that we do. GP services are trying very hard to continue providing online services, which a lot of people have found really easy to use during the pandemic. And at the same time, we're trying to increase the number of people that we see face to face, because that works for other people as well. And the balance between those two things is very difficult. I'm sure that your local surgery would welcome you joining conversations with them and their patient participation group around those kind of tricky topics.
Right, thank you. So Charles, Pascal, we're going to come to you, then Martin Waldron, and then Tessa Tullock. Charles.
Good evening, and thank you for the answers that we're getting through and so on. I want to ask a question about one of the Cinderella services, which is usually forgotten about in hospitals. But I have had through work the misfortune of visiting the pathology departments at Basingstoke and at the Royal Hants. And I've seen the one in Andover as well. And I'm amazed at the quality of work that they still manage to get out despite the facilities and so on. I can see that in some cases, and we all know how important pathology is, because COVID wouldn't have been sorted as far as it has been without PCR testing and the like. But it worries me that when one sees a GP and a certain test comes up, you get the response of, oh, despite it being NICE approved and recommended even, we don't do that in Hampshire. Is any money going to be spent at the Royal Hants and obviously in the new hospital? And will there be one pathology centre, or will it be in both? Because obviously it causes delays to tests.
Great question, Alex. Pathology.
Yeah, so I visited our pathology departments only this week. I was in Winchester on Monday and Basingstoke on Tuesday. So I absolutely know what you mean about the facilities aren't what we would want them. We are actually investing at the moment. So we've recently let a contractor replace a lot of the kit and to get them some new analyzers and equipment and so on. Pathology is really interesting. There's been a long, many years of debate about centralising the pathology services. And I think it's very like the rest of our services. There are things you want to do locally, and particularly taking blood from patients, you'd want them to not have to travel miles to go and give a blood sample. And in fact, a lot of GP practices do that really locally. There are tests you want really locally, because like COVID testing, we are doing that on Basingstoke and Winchester now, and we can get a result really quickly. And it means that when someone arrives at hospital, we know whether they might be COVID positive or not, and which ward to put them on and so on. And then there are some really expensive tests that cost loads of money, and you need lots of very fancy kits that actually you want to do in one big lab somewhere for a big geography, and accept that it might take a bit longer to get the result back, but actually that's the best way to do it. So we will absolutely be continuing to invest in pathology services, but we're not just doing it as Hampshire hospitals. We're looking at it across actually Wessex. So the pathology network is Hampshire, Dorset and Salisbury, and looking at how we make sure we've got real expertise in some of the super specialist aspects of pathology, and we can benefit from the bigger geography, but also do the things we need to do locally everywhere. Yeah, it's the same sort of message. Does that answer the question?
Pretty well. If you, I retired as a supplier. If you want somebody to discuss any of this with, please do yell. And I also happen to chair one of the ISO committees on the subject.
Okay. I'm also curious, and maybe offline, if there was a particular thing that was NICE approved that we weren't able to offer in Hampshire, we'd be interested to know about that, because we do try and make sure we do offer.
Thank you very much, Charles. That's great. Okay, Martin Waldron.
Thank you, Stephen. Thank you for letting me ask my question. I'd like to ask about IT services. My wife has treatment at Southampton and in Winchester, And it's frustrating that, for example, when she has a blood test, if a consultant in Southampton asks for it, we have to go there because we live in Chandler's Ford. And if the blood test is taken at the local GP surgery, the blood tests go to Winchester or Basingstoke to be sorted out. And then if there are any records at Winchester that the consultants in Southampton want to access, they can't. And so my question is, it's frustrating for us as patients. I guess it must be frustrating more generally. Are there plans to address that? And indeed, more generally, why aren't there integrated information services across the whole NHS?
Okay, that's a good question, Martin, and one I've heard many times. Chief Medical Officer.
Yes, thank you. Absolutely. You are completely right, Martin. We are as frustrated as you. So there is lots of work happening now, and this should be resolved fairly within the next year or so. So there's a real drive as we're digitalising more and more to be able to have interoperability between the hospitals and all the services within our ICS, the Hampshire and Isle of Wight. So for all the reasons you say, it's crazy someone has to go to somewhere to have a blood test. We are lucky in Hampshire that we do have a shared system called Chai that you can actually look at and get some of the results, and there are feeds from GP records as well as hospital records, but that isn't used as much as it ought to be. So it is something that we're working very actively on, and we recognise how important it is. And I think COVID particularly has shown us, because we've needed to come together and do things differently. And patients have moved and services have moved, and we recognise how difficult if the digital systems don't follow that. So yes, that is a very active piece of work at the moment, and I think being a formal ICS, as Steve said, will help some of those things. So there are other things that we're trying to do together as well, so that it's easier for staff to move between hospitals and different providers as well. And all of that we see is incredibly positive, because we shouldn't be making it more difficult for the people who use our services or the people who work in them.
Thank you very much. Okay, we're going to move on and talk about ED, A&E. And the reason I say that is because, you know, I've never yet met a constituent in 11 years of doing this who doesn't want to be taken to the right hospital to get the right treatment when they're acutely unwell. And bluntly, you won't know a lot about it because you'll be in a vehicle with a flashing blue light on the top, and you'll be taken to the right place. And so you would want to. The rub comes to maternity services, which we've already discussed, and A&E. I'm not sure we're ever clear what we mean by A&E. Emergency department, accident, emergency. People say to me, if I have a crash on the M3, I want to be taken to my local hospital in Winchester. And the truth is, you don't. If you ever smashed tonight at 3 in the morning on the M3, you most certainly do not want to be taken to Winchester. You want to be taken to the major trauma unit at Southampton, where they have a neuro unit and they do nighttime surgery. So we have a strange conversation where I'm not sure we're starting from the point that we're actually at on A&E. And I suspect that may be where Tessa Tulloch is wanting to come in and ask about A&E provision in Winchester. What does that look like in the future? Tessa, over to you.
Thank you very much, Steve, and the rest of you for setting this up. Yes, I just simply wonder, what are the plans for the A&E department in Winchester Hospital, which was so splendidly upgraded recently?
Shall I take this, Steve?
Yeah, maybe it's one for Alex. I mean, Alex, we work very closely on the money that we got for Winchester's A&E. You know, we've had this conversation many times. You know exactly what I mean by A&E versus ED and the services that are there and that haven't been in Winchester for years. What does the future of A&E look like in Winchester?
Yeah, so, and you're absolutely right, Steve. If you had a major trauma, you'd want to go to Southampton. As I said, if you had a cardiac condition, you would be taken to Basingstoke. But conversely, if you had a stroke in Basingstoke, you'd be taken to Winchester, because today different A&E departments have an element of specialism in different things. So, and they've changed over the years, and I fully expect they will continue to change. So I think the question about, so what will happen in terms of urgent care, if someone needs urgent care in Winchester, what will they be able to get at the Royal Hampshire County, is one of the things that we'll be talking to the public about. But one of the recent upgrades we did was to the children's area, and under all of our all of our proposals and options, a kind of a child who's hurt the finger on a football pitch would be able to go to the Royal Hampshire County. The minor injury type services in any proposals would still happen there. Much of the kind of the illness, the minor illnesses, a variety of things that happen that people walk into an A&E for, they would be able to still come to the Royal Hampshire under a number of our options. The issue is where do the ambulances take you? And again, if you're in an ambulance, you probably are less bothered about where you go. You just want to make sure the people at the other end know what they're doing and have the right skills and the right equipment to look after you. And the options that we'll be talking to the public about will have different scenarios there with where the ambulances might take you.
Okay, I hope that answers your question, Tessa. A question that's been sent in to me around COVID vaccines and the hospital staff. Have all the hospital staff now had both their vaccines, Alex?
Over 90% have had both their vaccines, and Lara's been our executive lead on the vaccine programme, so this has been her life a little bit for the last little while. So over 90% have. There are some that haven't, and there are some. So pregnancy was contraindicated at one point, and people who are pregnant were advised to talk to their GP and consider whether they wait until after their baby's born before they have the vaccine. So we have some staff in that situation. And, because we're always completely honest, we do have a small number of staff who have chosen not to have the vaccine and haven't shared their rationale, but it's a very, very small number. Over 90% have had both vaccines.
Okay. And how many patients do we currently have in Winchester Hospital with COVID?
None in Winchester, I don't think. Lara, is that right?
Right, yeah.
Okay.
Nobody.
Okay, thank you very much. Anybody else would like to raise a physical or metaphorical hand and ask a question? Okay, Anne Beeching.
Thank you very much, Steve. I'd just like to know what the plans are for follow-on treatment. When somebody's perhaps been in and had an operation or some other problem which need to be looked at on a regular basis, and physiotherapy seems to come to mind particularly. Physio hasn't been very good for a few years, and obviously it's worse now with COVID. What are the plans there? Or is it still going to be sort of hived off to private organisations? And if so, what quality control is there? Does that make sense?
Follow-on treatments.
Yeah. So, I mean, in terms of our plan, so follow-on treatments on the whole are absolutely suitable for providing in a lot of different locations. So, we do a lot of follow-up out at Andover, at Alton. We would absolutely expect to continue doing follow-up at Winchester. The specific question you ask about physiotherapy and private providers it might be something Matt wants to answer. So ongoing physiotherapy is something that has been subject to tendering, and different providers have won the contracts for that over the years. So we do at Hampshire Hospitals provide quite a lot of physiotherapy through our own teams, our own staff, but there are some elements, you're right, that the contracts have been won by other providers. It is interesting, part of the legislation Steve's talking about is sort of backing away a little bit from this putting NHS services out to tender. If there's a good rationale for keeping them in existing NHS providers, then there's more, CCGs have more options, I think, about not tendering in the future compared to where they've been. But I don't know, Matt, do you, in terms of the CCG's philosophy about tendering?
I mean, currently the CCG has to follow the tendering rules essentially, and contracts over a certain sum have to be put out to tender. There's a very specific process. They have to be advertised in the European Journal of something or other. If there's a specific issue, Anne, I'm really happy to pick it up offline. If Steve's office can connect us, I'm happy to look into whatever the specific issue is with the private provider.
I just wondered what control there was on quality.
So CCG, the CCG has a large quality team which works with all of our providers, whether they're NHS providers or private providers, to look at the quality of the services that are commissioned and provided. So private providers are no exception. So we'd very much want to know if there were quality issues with any services that are provided.
Yeah,
So I'm very happy if Steve's office passes on my email on that.
I haven't personally got any, but you
know,
know,
okay.
I have heard, yeah.
Thanks, Anne. Okay, and if you did want to connect with Matt, then you obviously, I have your details, so I wouldn't do that, but if you email me again and say you want to connect, then I will copy you in. Okay, thank you for that. Mr. Chong, Bowman Chong.
Thank you. I have one question, but since I have the Chief Executive and the Chief Medical Officer here, can I just, on behalf of many of my friends and neighbours, say a very big thank you to the hospitals for the great work that they did to get us through the COVID crisis. My question is, do we have a rough time frame that we'll be able to tell the public what the options are? Alex talked about the option early on. A time frame to tell people what the options are and which hospital would get what treatment. That's my question. Thank you.
Okay, who would like to answer that? Is that a commissioner question or is it a provider question?
It's a Hampshire Together question. So it is the $1 million question at the moment, because we, as Steve said at the beginning, we were hoping to be in consultation, having that conversation around about now. There is this extra bit of work we need to do to align our options with the National New Hospital Programme, the 40 hospitals. And at the moment, we're not quite sure how long that piece of work is going to take. So we can't commit to saying we'll be out to consultation, you know, in September or by Christmas, or we can't say because we just don't know how long that extra bit of work's going to take. But we're hoping it's not too much of a delay. The one thing we are that the central team have absolutely said to us that we're committed to is it won't affect the building date or the works date, because we're in the programme to get the bulk of our capital money between 2025 and 2030, and that will still be the case. But Bowman, can I take an opportunity as well? Bowman is one of our governors, and he has rounded up his neighbours and his friends and delivered mince pies and cakes and gifts and everything to our amazing staff. He's just such a supporter of the hospital, and our staff are so grateful, Bowman, for what you do for particularly Winchester. I know you've also spread it to Basingstoke and Andover, but Winchester is where your heart is, isn't it? And our staff feel really loved by their community, and you're a big part of that. Thank you.
Yeah, and I just want to echo that. Thank you, Bowman.
That's very sweet. Thank you. Okay, Charles, I'm presuming that's a new hand and not a historical hand, in which case, back to you.
Yes, and I don't know whether this is part of Hampshire Together or not, and maybe Steve might have some input on this one. Dental care. Obviously, if things go wrong with your teeth, you can end up with cardiac conditions and goodness knows what. Trying to get hold of an NHS dentist, certainly in Winchester, is something that you're looking at 6 months to even register, and then probably another 3 months thereafter for an appointment. And if you actually have an acute condition, or let's take a broken tooth, and you ring 111 or whatever and say, how do I get help? They say, oh, you have to be registered with a dentist and then we can do something. But you can't get registered with a dentist without waiting 6 months. Is this actually going to be looked at to try and prevent what must be a huge amount of increase in drugs bills and goodness knows what as part of the whole project? Or is it something that Steve will be taking up in Parliament?
Well, as a former dental minister, I can tell you it was the most challenging bit of my brief. There we have been trialling a new contract with the dentist profession for years, seemingly forever, and it's been incredibly challenging. There is a lot of NHS dentist provision in the city. I've opened a number of them, and I'd be very interested to follow up with you as casework offline about that if you're having an issue yourself. But you're absolutely right. When we get it wrong on dentistry, then it falls over into the acute sector. People turn up at A&E with dental problems, which is not what we want to happen, and it's a real problem. There's a lot of in the new legislation that we're talking about in the new health bill, we are going to make it easier for water boards to put fluoride in the water, which is controversial. But actually, all the evidence that I ever saw as a minister was that it helps prevent cavities, and I think it is something that we should make easier for local communities to do. But Matt, you will know from your conversations online with MPs in the last 12 months that dentistry has come up a lot. Admittedly, not that much from me. I haven't had much casework on dentistry problems, but certainly from some of my neighbouring colleagues, it's come up an awful lot. It's a big challenge in that part of primary care, isn't it?
It is a big challenge, and it has come up a lot. And you're right, Steve, not a huge amount from you, but certainly from other MPs in the area, it has come up quite a lot. Dentistry is one area which is not commissioned by the Clinical Commissioning Group. It's commissioned directly by NHS England. We do liaise with them on dentistry, so certainly we have a kind of two-way conversation continually with them, really. And the information that they've provided us with recently is that NHS Dentistry is open, so all dental practices are open. Whilst, like Alex was saying about the hospital, they're also having to deal with a reduced capacity because of all of the COVID rules and the cleaning and the distancing and everything else that they're having to do to keep their work safe for both their patients and their staff. But they are open. During the first wave of the pandemic, there were a series of emergency dental hubs which were opened, and those also remain open for patients with urgent dental problems. But I'm sorry to hear that you've had trouble with it, Charles.
Yeah, no, it is a big challenge. It's not something that comes up a huge amount in my postbag, as I say, but I know when it comes up, it really comes up, and it really hurts. So no, thank you for raising it, Charles. Now, Richard is waving in the real world way.
Good
Mr. Chisnell.
Good evening, everyone. Thank you very much. And can I echo the praise being heaped on our team here at Winchester, because they thoroughly deserve it. And as a regular recipient at a ripening age of all sorts of treatments, I can only admire the professionalism and the expertise of all those I come into contact with. The simple question is, carrying on from dentistry, is there any likelihood that orthodontics will be removed from Winchester? Because I have two grandsons going through consultations and they've been told that it's closing. Is that correct?
Lara, Alex, one of you?
So I am not completely sure about that, I have to say. Alex, do you know? Because we do very little orthopaedics in the hospital, as you will appreciate. The majority of orthopaedics is done
orthodontics, Lara.
Orthodontics, sorry.
Yes.
I'm talking about that. The majority is done in the community. Alex, are you more up to speed with what's...
So I know that it is one of our quite vulnerable services. So we sort of had, I think, half a whole-time person who came to Winchester periodically and was looking to retire. And we've been out to try and find new orthodontic surgeons, and they're not easy to come by. So it is one of these things that's been a little bit under review. And I think we did stop the service for a while, and we moved a clinician down from Basingstoke to cover some shifts for a while. So it is one of the services that is quite difficult for us to sustain at the moment. But yeah.
Thank you.
Thank you. That's very honest. Could I ask, in respect of the new build, which people ask me, and I think it's a legitimate question to ask, Alex. What site search have you done, and have you considered other sites in Winchester for this new build?
Yeah, absolutely. So when we found out we were on the national programme, we commissioned some experts to scour the county and look for suitable sites. And they came up with a list of, oh, now the number's gone out of my head. I think it was 9 possible sites was the original long list, which did include some within Winchester City Council area, not kind of right in the middle of the city centre, but on the outskirts. We then ranked those using a list of criteria around accessibility, around likelihood of planning consent, around a whole load of other things, and got it down to 5, which still had a site within the Winchester area. And we then commissioned some other people to go and talk to the landowners of those various sites to say, are you interested in selling, at what kind of a price? And through that process, that's how we've ended up with the 2 that we've got remaining, which is the Junction 7 site and then a rebuild on the Basingstoke Hospital site. So unfortunately, the 3 that were in the Winchester area in our original list sort of dropped off through that process, either not available for purchase, somebody already had an option to buy that lasted a number of years, and or were not big enough. So I know there's been particular interest in the St John Moore Barracks site and whether that was an option, and that was not a big enough site with the expectations around how tall you could go. So there's, we can have a smaller site if we can build a massive tower block, but if we think that all the advice is you would need to keep something relatively lower, then you need a bigger footprint, and it didn't meet the criteria. It just simply wasn't big enough.
Okay, no, that is very honest. Okay, would anybody else like to ask any other question? If not, then we will wrap and let you go and enjoy your evening. Okay, Jeff, Mr. Bennett.
Have we got a date for the new build yet? Presumably the site has now been established. Do we know when it's going to be, when the build is going to start? And when it is in action, presumably it will feed also with Basingstoke as well. And hopefully it will mean that we won't, from the county hospital, have to go up to Basingstoke for certain things. Well, presumably there will be a reciprocity between the 3 centres. Is that right?
Okay, thank you, Eric. We met earlier in the week, didn't we? I think you were on one of my Visit Westminster things. Alex, Eric's question.
Yeah, I didn't quite hear all of it. I think it was, what's the date and will you have to go to Basingstoke when it opens? Was that the main questions?
Yes.
Yes.
But at the moment, we have to go to Basingstoke with certain tests.
Yeah, so the national programme, we are in the second half, which means between 2025 and 2030. We have a plan, so we obviously need to consult with the public about which services go to which sites, and also we still have these 2 options of sites, the Junction 7 site or the current Basingstoke Hospital site, and that will be part of the consultation as well. We then need to finalise our proposals and then take them to Treasury and say this is good value for money, and there's various business case stages that need to get approved. So our expectation is that, and what we're trying to work to, is to start building in 2025, which is the earliest we can in terms of being as part of that 2025-2030 sequencing. And then the expectation is it's about, if it's on the Greenfield site, the Junction 7 site, it's maybe a three-year programme. So that's our working plan, but we need to work through with the national team, new hospital team, to check that that's aligned with their sequencing around the other 39 hospitals that are being built. And then, as we said, the bit about who has to go where for what services is all part of the consultation. But the expectation is that for the things that people visit for most often, that will still be in Winchester. And then for the kind of once or twice in a lifetime kind of visits, either or maybe slightly more if you have slightly bigger family, but potentially for the obstetric visits if you're a high risk mum, or for a serious big operation, you might have to travel a little bit further to the near site.
So presumably the services that will be provided in this new hospital, as you've already indicated, you haven't any precise arrangements yet.
No, we're working on the 2 different sites at the moment. Yeah.
Thank you.
Thank you, Eric. Fran.
Oh, thank you. Sorry, I've had some internet connection issues.
Yeah,
so
you're Fran Goulder, yes?
I am Fran Goulder,
Okay,
yeah.
I asked your question earlier when you ducked out about beds and about appendicitis, for instance. But why don't you put it in your words and Alex can come back.
I'm one of the consultants at Winchester Hospital, and I know there's still debate as to what's going to be done in Winchester and what's going to be done in Basingstoke. But I would like to hear from Alex or Lara clearly. I know that the plan is for outpatients to remain in Winchester. I know that the plan is for people to be able to come in and have scans and endoscopies and sort of day case minor things. It seems to me that what makes a hospital is having ill people in beds. And I would be very interested to know whether there will be any inpatient beds, how many inpatient beds will be in Winchester. And I know there'll be a hospice, but that's a bit different. Can your appendicitis have their appendix out? Can your mum with the urinary tract infection be admitted for a couple of days of antibiotics? If I got a chest infection, could I come in and have some antibiotics and some oxygen? These are not rare things that need to be sent to a tertiary referral hospital. They're very, very common, very frequent. At the moment, we've got, I don't know, 300 beds full of patients having done. Is the plan for all of that to go to Basingstoke?
Can I take that, Alex?
Yeah, go on, because I answered it before. You go ahead, Lara.
Yeah. So, Fran, as you know, we're still working up the options. So depending on the options is a very different answer. But what I will say is, Alex was talking and Steve said, what have you learned from COVID? And what we've all learned, haven't we, is the need to be able to separate our elective or planned surgery. So our desire for Winchester is all the things you mentioned, outpatient scans. We absolutely want to be able to see people who have minor injuries, minor illnesses, and to have a planned surgical centre. So not just day case, but actually all surgery, even if it requires an inpatient stay, not if it is likely to require the support of intensive care, because that we see a benefit in centralising. So all of your examples are emergency admissions. Now, if an operation clearly is an emergency, requires admission, if that happens, then we are wanting to centralise that into our acute hospital. And there are many benefits. And as you know, surgery for children, paediatric surgery, your 12-year-old example with appendicitis, it is better to have that at a larger scale. So we recognise that that means some people are going to have to travel further. And for people like you who do a brilliant job providing a fantastic service in Winchester, that is a significant change. The advantages are that we are able to expand the planned surgical centre and protect that from the urgent emergency admissions. And everyone will know in the winter pressures and during COVID that we had to stop our planned surgery because we couldn't either keep people separate and safe or have the capacity. So this gets around it, and this is about the learning from COVID as well as our winter experience each year. But the options are being worked out. So we are going to have people in beds, as you say. The number of beds will depend very much on the services that we provide, and the different options have different services between them. So, but I think
it would be fair to say that the vast majority of admissions are emergency admissions, wouldn't it? So pretty much all of the medical admissions are emergency admissions. So if you don't take emergency admissions, you don't really have a hospital, an inpatient hospital. 95% of our patients in hospital at the moment are probably emergency admissions, Lara?
I don't think it's quite that high, but it is for medicine, it would be that high, absolutely. But for surgery, it's probably not quite that high. But actually, as we've developed our pathways, many people are seen, aren't they, in what we call same-day emergency care, or SDEC, and they can be, so not for an operation, but people with medical illnesses are often assessed, diagnosed and have their treatment, and then are able to be cared for at home. We've got virtual wards that support that. So we admit far fewer people than we used to admit for certain conditions, but many still need to absolutely come in. So this is the clinical advantages are doing things at a larger scale and separating the emergency and the planned aspects.
Okay, but for the avoidance of doubt, the vast majority of our hospital beds and the vast majority of the patients currently in hospital and the vast majority of ill people in Winchester that need to be in hospital would go to Basingstoke, wouldn't they?
The new hospital is not a Basingstoke hospital, so it would be the acute hospital. But actually the vast majority of people coming to Winchester Hospital are coming for either an outpatient or an investigation, or to be seen in A&E and go home again.
Okay, thank you.
Can I just come in briefly as well, because of course emergency admissions are a big part of what a hospital does, aren't they? But one of the frustrations that I hear from the patients that I talk to, and indeed some of your surgical colleagues, Fran, is the difficulty that comes from not having a separation between emergency care and elective care. So it's not uncommon, I'm sure, for you to have routine planned operations cancelled because people have been admitted overnight as an emergency into a bed, and there's no longer a bed for your routine patient to be admitted into. And one of the objectives of the programme is to separate out those two so that doesn't happen. I saw a patient the other day who I'd referred to the gynecologist, and she'd gone up to the hospital, she's seen the specialist, and she's been told it's going to be a year before there's any kind of chance of her having some kind of routine operation. And these kind of things are a huge frustration for patients, and they're a huge frustration for our colleagues as well. And so I think just to look solely at the emergency side of things is not to see the whole picture.
But the vast majority of my elective operations will also be done in the new hospital, which is predominantly Basingstoke way. So my elective patients are going to be moved up the road, as are my emergency patients, as are the vast majority of people that need operations that I would be looking after. And I don't think you can imagine for a second that the COVID backlog would disappear if we had two hospitals doing different things. That's just not going to happen. There's a massive backlog everywhere in the country, and indeed probably in the world.
And on goes the conversation, and that's what I said at the start. That's what this is about. This is about being honest about the gains, the trade-offs. Okay, Ingrid Bond, final question, and then I will wrap.
I've been shielding since the 13th of March 2020. I've had the good, the bad and the ugly from the NHS. I was admitted as an emergency to Winchester. My concern, the brain was still focusing, was hygiene within the ward. There was a very rudimentary cleaning of the ward. The bathroom was shared with 5 patients. I had excrement, I had samples there. There was no access to the shower. I wonder what the contract is for monitoring that. It doesn't matter about the nurses, the nice clean sheets in the bed, but I worried about going out with more than I went in with, which was just before Christmas.
Okay, Lara.
Yeah, so I'm sorry to hear that. That's not good at all, and that isn't the standard of hygiene or cleanliness that we would expect at all. I mean, our domestic team are part of our staff. The areas should be checked very regularly. And during the pandemic, we have significantly increased the cleaning that is going on, particularly in areas where people were first coming in. So we've been separating the streams of people who are likely to have COVID or don't have COVID. But what you mention is fundamental cleaning, which is really important. So the monitoring, we have, so our domestic supervisors monitor the ward teams, nursing teams monitor the cleaning and the matrons, and our infection control teams, which have massively expanded during COVID. So I'm very sorry to hear that, and we'll perhaps pick up where that was. But we do take this really seriously. And actually, we also monitor to look at infections that people have and where they have got that. So it shouldn't happen at all.
No, but I do have photographic evidence of that bathroom, and it was disgusting.
Okay, no, that's not good at all. So perhaps through Steve, we'll contact you to find out.
By all means, send that to me, Mrs. Bond, and I will connect that through to Lara. Okay, to 7:30, so I will close, and I will say thank you. It has been beaten to it on many occasions by many people to say thank you to our NHS team and I mean the wider NHS team in Winchester. You continue to amaze and please us. Thank you for everything that you have done and that you will continue to do, because the day job continues in the NHS long after the pandemic has gone, and the day job just got bigger as a result of the pandemic. So thank you so much for everything you've done. The Hampshire Together programme is a big piece of work. It's going to continue, and there will be ongoing discussions. I'm always here to act as a bridge between constituents and the trust. Please come to me with questions. I'll do my best to get you answers, and we will have more of these sessions if people feel that they are useful. But the only thing I can add is that if you care about our hospital and you care about our services, then speak up, get involved, and make sure that there are as many people on this call next time as we invited, because they will have a view if there are service changes proposed, and now is the time to speak up. Thank you very much, everybody, for being involved in Ask the NHS. We'll see you next time. Stay safe.